Okay. We're going to give just a few minutes for everyone to get logged on, and then we'll start. Thank you. Good afternoon and good almost evening, I guess, some places. Uh, welcome, and thank you for joining us today for our kickoff to Safer Births Now, which is a virtual maternal health fair. For those I guess I don't know everyone, but my name is Marie Boone Clark, and I am the founder and executive director of Birthing the Magic Collaborative, which is a 501(c)(3). And our purpose is to create and facilitate these types of forums. We curate virtual education for Black birthing people and those who care for them. So we are so humbled to have such amazing experts join us this week for our entire week-long fair. And I am particularly humbled to have these two women that I have such admiration for joining me today for the conversation. I will not attempt to give you guys their bios. I'm sure you saw them, but one of the things I always say is that words on paper do not give justice to what so many people like Dr. Fleming and Dr. Bonaparte are doing in real world. So the first thing I want to do, Dr. Mary Fleming and Dr. Alicia D. Bonaparte, and ask them to tell you what they are doing. What are you guys doing? Why are you here? And why did I stalk you? What made me stalk you? Dr. Fleming?
Well, I can work my mute button today. It's always the things that we do every day that works. Well, thank you so much for having us. This is an honor and a pleasure to be in the space with both of you all to talk about something that is very near and dear to my heart. And so, in general, I mean, like you said, the bio has the words, but I think why I'm here is that I have always been interested in making the world better for everybody, and especially for people who look like me. And we know that the maternal health crisis has been a crisis for a long time, not new, but has gotten some more media attention and seems to be top of mind. So it is a great time to kind of double down on continue the conversation around it, but in the context of health equity in general. I think we've come a long way. We still have a lot of work to do. And so my work as in my everyday life, I guess, which maybe everyday lives, but I do a few different things. But I'm still super excited about um, being able to practice clinical medicine. Seeing a baby born is unlike any other thing you can see in the world. And being in the space of joy with so many people is a gift. And so I'm super humbled by that. And I do like to continue the conversation around health equity. I say health equity should be an everyday conversation, and we should insert it whenever we can, in helping people grow to understand what that really means, what that work means, how they can understand it, but also how to share it with others, because that's how we make change and broaden the conversation places that it wouldn't normally be. So with that, I will pass it over to Dr. Bonaparte.
Hi, everybody. I'm really excited to be here, and in particular to be in conversation with the two of you, Marie and Dr. Fleming. This is just a very exciting moment for me on a number of different levels. So I am a professor, but I'm also first and foremost a midwifery enthusiast. I think that would be the biggest thing that I would say, particularly Black midwives. I study them. I love them. I love being in conversation with them. A couple of years ago, I actually co-founded a conference called Midwifery's Public Health. And part of the reason for that was to really emphasize how and why the work of Black midwives in particular has just been so instrumental in regards to bettering outcomes in Black maternal health and infant outcomes as well. I'm also a consultant. I do a lot of work on medical mistrust, particularly among minoritized populations. In addition to that, I have served as a birth justice educator for Elephant Circle, which is based in Colorado. And then last but not least, I think the biggest thing that I would say is I largely want to make for sure that people are not only aware of the history of Black midwives and what they've done in regards to making for sure that there's better outcomes, but also highlighting the work of people, particularly Black midwives today, that are doing that work, most particularly in the South, right? So for me, that's like my big thing is just let's talk about what's going on, and let's also think about the fact that we can actually effectively make change in regards to how practitioners and patients have conversations with each other. So thank you so much.
Thank you for that, Dr. Bonaparte. I know I'm going to deviate a tiny bit from what we had talked about doing, because Dr. Bonaparte, you said I'm a professor. I know, and I think your bio said that you are a medical sociologist, but for the average Joe like me, a little girl from Kentucky, can you tell us what a medical sociologist is?
There's a number of things that we do, so I'll tell you what I do. So I'm very much so interested in thinking about how we view health, illness, and also the medical system, and how and why those interpretations of that, whether you're from a patient perspective or from a clinician perspective, may be different. And then also bridging why there's a communication gap that oftentimes happen. I'm also interested in looking at how structural processes influence how we think about health and illness. So why is it that many people who are poor are considered to be non-compliant when in actuality, sometimes they can't afford to actually go to the doctor on a repeated basis because they're having to give up work, in essence, which is money for their families? What does it mean when patients experience things like a white coat syndrome? So for example, your blood pressure rises up as a consequence of being there, and then there's a story that's behind that. So for myself, I'm very much so interested in looking at different axes of oppression. So the isms that people are mostly familiar with, like racism, sexism, classism, ageism, all of those kinds of things. How does that influence how we approach our own health, the types of decisions that we make, and then also the interactions that we have? And I find that teaching this kind of stuff, not only to my students, but also doing it as a part of the consultancy work that I do, allows for people to have a better understanding of the landscape that actually happens, how and why there are communication deficits, and also what are the really effective bridges that exist to actually make that gap considerably smaller, and hopefully, for all intents and purposes, really just completely get rid of it altogether. So I would say that's a nice amount of like what I do as a medical sociologist. Some other medical sociologists, though, study things like epidemiology, engage in public health, and things of that sort as well. So looking at disease transmission. So I talk about that too, but my main focus is how do we think about health and illness, and how do we navigate that when we're in clinical spaces? Mm-hmm.
Thank you. Thank you. I always think it's important to get grounded. I remember there was years ago, Mary J. Blige, with one of her first financial woes, made a comment about never being afraid to admit you don't know, because she said she got into her financial woe because she didn't admit that she didn't know. So that was an aha moment for me, because I am now much more comfortable saying, I don't know. And although I stopped you about your book, right? It was like, I really don't know what she does. So here's another confession. I think we often don't know what we mean by bias, right? For those of you who signed up, there was a reason you signed up for this workshop. But we don't talk about bias in terms of, with clarity. So looking at it from your respective lenses, how do each of you define bias? And then that'll help level set as we go into this conversation, I think. Dr. Fleming?
I think starting with all humans have bias, right? And so it's not, and it doesn't necessarily have to be bad. I usually use the example, so I'm from Louisville, Kentucky, and I'm an avid University of Louisville fan, right? I do not like Kentucky fans. I don't like, I tell everybody, that's fine. My family, we all feel that way. We have a bias towards University of Louisville, like many people who are sports fans have a bias towards their hometown team. So that is what we would call an acceptable bias. Bias, when it's unacceptable, is when you would treat people unfairly because they don't align with your circle of knowledge, right? And so if I were to treat a University of Kentucky fan poorly, that would be unfair bias, right? I still need to treat them as a human being and give them grace, even though I don't like their sports team of choice. And so what we want people to do is acknowledge that we all have bias, but help us understand that when that bias interferes with the work that we do, especially in the healthcare system, that can influence a negative outcome on our patients, that's what we get concerned. And then we want to make sure that when we, name a thing, and then understand there's always levels, right? And so there are bias that we know, right? And we understand and we hear very harsh negative words towards groups that we don't like. People see that, understand that. But then there's biases that we don't often recognize. So those are the implicit biases that people talk about. And that's the part that we as a group really need to work on, because we don't want to discriminate against people when we see them in the healthcare system. We don't want to silence them when we see them in the healthcare system. We don't want to ignore them and not give them proper care. And then that's just on a one-on-one basis. And the things that happen on these individual levels infiltrate into the healthcare system as a whole. And then we talk about systemic bias, right? And those are harder to sometimes wrap your mind around, but those are the things that are really, really hurting us as an entire people, but especially the marginalized population. So maybe I'll stop there, and then we can have the one.
No, I think that's a perfect framing for what we our purpose for the conversation today, right? And so I also would love, Dr. Bonaparte, for you to discuss, sort of the historical narratives that continue to impact. Let's bring it in a little bit more now. We talked about bias. Can we bring it more specifically to the treatment of Black birthing people? Can you walk us through how we arrived at this point? And feel free, we're in your classroom today. Feel free to use your slides if you want. But when we leave, we want to be educated.
I really appreciate you sharing, allowing me to have this space to be able to do the things that I do in my classroom spaces, right? So one of the things that I always find is extremely important is to think about, we can't say, how do we get someplace without looking at history? So what you're looking at in front of you right now is an image from a painting. This painting is actually titled J. Marion Sims, Father of Gynecology. It was actually funded by the Park Davis Pharmaceutical Company. They commissioned this art piece. And for those of you who may not be able to see everything, I'll just kind of describe a little bit to you. So there's an enslaved woman by the name of Betsy who is sitting on the table that's right in the middle of the piece. And she is surrounded by 3 white medical men. And over to the left, you'll see 2 Black women. They're also enslaved women who are kind of peering behind the screen to kind of see what's happening. So of course, this looks all nice and lovely. It seems as though she's being very respected, but you also will notice that she actually has her hand over her breast, right? So I would argue that that's probably some elements of trepidation. And so when we think about this picture of medicine and its medical innovations and how it actually develops, one of the things that we actually find is that it wasn't as pretty as this image kind of makes it seem, right? These were actually very violent encounters. And part of the reason why I'm using this term violent, and I'm doing that very purposefully, is to talk about the fact that many of these women did not have a choice in being a part of these processes. So, for example, the development of medicine is oftentimes based upon experimentation, and early experimentations were happening between agreements between slave plantation owners as well as medical doctors. And so what we see here is that Betsy, although she looks calm to a certain extent, what we find is that this is actually a very violent thing. Two other pieces that I would argue that are really important to kind of think about this is that part of this medical experimentation happened largely as a consequence of this belief, right, rooted in scientific racism, that Black people have a higher tolerance for pain. So as a consequence of this, the development of obstetrics and gynecology, and this is no offense, of course, to you, Dr. Fleming, I know you're an amazing and wonderful GYN, but we have to talk about this history. Like, why is it that people believe still today, right, that Black birthing people have higher tolerances for pain? So as a consequence of this, what you found, I apologize, I'm in an office that has sustainability measures in my lighting, so the light may go on and off as I'm talking to you all. But one of the things that I think is important to discuss, right, is that when medicine really started pushing this idea that birth can only happen within hospital settings, and it can only happen under the supervision of a medical doctor, and with also their interventions, it started to shift and to change how and why birth is no longer seen as something that is natural. So you mix that with the bias, right, which Dr. Fleming did a wonderful explication of earlier, you start to see the consequences of this very early history. One is Black women are 3 times more likely to die from a pregnancy-related cause than white women. And in addition to that, Black women, unfortunately, are still almost 25% more likely than white women to have unnecessary C-sections. So this is from my own research, and this is also coming from a study that came out not very long ago through the National Bureau of Economics, in which they studied 1 million births. And these are the things that they found. So again, it begs this question of, why are people distrustful? And this is why I always argue that Harriet Washington's beautiful book, Medical Apartheid, in which she talks about this term called iatrophobia. And with that term, what she's really trying to explain is this is how and why Black people are largely distrustful of clinical spaces. And I think that iatrophobia can be expanded to other minoritized populations too. I don't think it's just related to Black people, but she uses it as a way of kind of talking about how and why people are fearful. And then last but not least, I think if you consider that Black folks are orators, we tell stories all the time. And so if these kinds of stories are consistently shared, it makes sense why people become afraid, particularly when we talk about the unfortunate study that happened in Tuskegee, for example. We think about Hornblum's discussion in Acres of Skin about Black men being experimented upon as they were incarcerated inmates. These histories start to make a lot more sense. So thank you so much for your question.
You for that, Doctor. I'm going to go back, and if I get remedial, somebody in the audience say, Marie, stop. But I wonder if everyone knows the Tuskegee experiment. Can we share briefly what that is, or why it is something that would lead to angst or mistrust?
Or which one? I don't know if I'll do it the same justice as Dr. Bonaparte will. But and we talk a lot about Tuskegee, and the example that Dr. Bonaparte gave is excellent framework for distrust in the maternal health field. But it goes much broader than that. Experimentation on Black and brown women, and especially for Black and brown women being sterilized and having hysterectomies without their permission in this country and in other countries. I think Tuskegee, it just had more publicity, I guess, if you will, but it was a group of Black men who, they call it the syphilis experiment, of course, and it lasted for long, long time. I think it was a decade or better, right? And where the men had syphilis and were coming and getting treatment, but not. And they were studying the natural progression of the disease when that work had pretty much known. And so they were withholding known treatment for people for many, many years. And so you can imagine if if that is the narrative of, if you go to the hospital or the clinic for help and somebody experiments on you without your permission, withhold medication that's simple, not an expensive or experimental medication, and allow you to suffer for years. Especially, it created mistrust in the medical field in general, but especially within clinical trials, right? And that in clinical trials is how we gain new treatment mechanisms and therapies. And Black people generally have continued to be excluded for proper trials or are too scared to be in them. So the ripple effect, even though that was in the 70s, is still present.
Mm. Thank you. Dr. Bonaparte, did you want to add anything from your perspective, or?
I mean, I think my only small addition is just that when I teach about it in my classes, I never refer to it as the Tuskegee study because it makes it seem like the city of Tuskegee in Alabama, right, a predominantly Black town, agreed for these things to happen, when in actuality, this was a US government, Department of Health and Human Services decision to do this, not only the withholding of the medication to treat them for syphilis, but also this belief of we can use them to just study how this particular disease migrates through the body, right? And for me, that's the thing that I think is just so important. It's like, it's not that the city of Tuskegee said, we agree for these heinous things to happen to us, but instead these were decisions that were made and we were told particular kinds of things. And then the last thing I was going to say just really quickly in conjunction with what Dr. Fleming very eloquently said earlier, and that is when we think about medical innovation, yes, we do have to have experiments, but there also becomes a conversation about ethics. And so again, when I teach this in my classes, right, when we think about ethics, ethics is, I would argue, a really nice counter to bias, right? Like, so I may have these beliefs or ideas, but are my practices ethical, right? And I think that is the point that I think I'm hoping for people to start to think a little bit more about when we think about bias and what are some counters that we can do to it, is thinking about how can you ethically engage in experimentation, that you're not exploiting people and that people are actually receiving treatment.
And I think that's, what leads to a perfect lead up to our my next question. I would encourage our audience to, and I love Dr. Bonaparte, how we frame things, right? Because if it had it been a study, it would have involved informed consent. And I think one of the things that as I've learned over the years about this incident, right, was how there was a lack of concern for not only those men who were suffering, but if anyone knows anything about syphilis, it's transmittable, right? And so their wives, their children suffered consequences as well. So when we talk about patterns, and as you just mentioned, Dr. Bonaparte, questioning, not only is it ethical, but then what's the impact in a broader context. Sometimes when we talk about bias, the pushback is that people assume that they're being accused of racism or bad intentions. What do you say to those who conflate bias with blame?
I love this because it pushes us to really think about this notion of being self-aware, right? Because I think at the end of the day, bias is insidious. It's like a germ or like a virus. It gets into the system, it gets into society, and then people just have it. But then this is the next step, though, for me but it's about being self-aware and also just being aware of our intentions, even when we think our intentions are good, right? And so it becomes this thing about, am I actually being beneficent? Am I actually doing the good or doing for the good of my patient as I'm having these kinds of encounters? So for me, I always think if you are a health professional, right, and if you're being provided data that says, well, listen, as I had mentioned before, poor people tend to be non-compliant, or folks of color tend to be non-compliant, or trans folks tend to be non-compliant, then perhaps you won't ask them certain things. Like, I won't ask for you to follow up because I think you won't do it, right? Or I might tell you not to have any more extra tests because I don't think that you're likely going to do those kinds of things. But at the end of the day, if we start to realize at the heart of non-compliance for these groups, it's not only the iatrophobia that I was talking about before, but I think it's also an inability to be compliant because of maybe, for example, you don't have health literacy. So it becomes this question of if you're taught a certain thing, then you're socialized to behave certain kinds of ways. And I think that is the part that I think is just really, really important for us to consider in these kinds of conversations. The other thing that I always think about too, right, is how and why certain narratives are placed on people, right? So again, as you were mentioning earlier, Dr. Fleming, you were talking about unconscious bias and as well as the implicit and systemic. That unconscious stuff, right, is that I don't think that people just come into the world wanting to engage in racism, right? Like, I think you're socialized to believe that this is what you should do for a variety of different reasons. And that's a whole nother conversation, a different workshop, I think. But I think at the end of the day, I do think it's important to consider this notion of not necessarily conflating bias with blame, but more so pushing for how can I be a lot more self-aware about the things that I'm doing and taking a step back. And I think just using that small space and time of taking a step back and saying, am I doing something that I was taught? Or is this something that I truly believe? And if it's not something that you truly believe, therein is where I think true social change can actually start to happen. And I think that there's been studies that actually show, right, that when the training actually occurs, people become much more self-aware.
Which is sad. I said earlier, like you have to name a thing a thing. And I think we have to have these spaces where we can talk about it freely and honestly, acknowledge again that we all have biases and that's okay, but not let that impact the world in a negative way. And I do think it needs to be um, incorporated in all healthcare education, right? So you need to think about these things. It's like Dr. Bonaparte said, we're all socialized in different ways for different things, and not all those things are bad. But if we don't have the space to be introspective and understand which of those things are good and which of those things could be negatively impact others, then we don't know how to do the work. And the work can't start once we get to the hospital or the clinic, right? And the work can't just, and it has to be healthcare broadly. Because, when I'm going to call you Miss Marie, even though you're going to slap my hand. When Miss Marie and I we're talking, and because we think it's just the clinicians, right? But how many people touch a potential patient before they ever get to me, right?
Mhm.
So many, right? And when you're thinking about how do you hire your front desk person, you have to think about hiring somebody that's going to understand the community that you work with. And
Mhm.
so every part of designing a healthcare experience has to be intentional. And then in addition to what Dr. Bonaparte said, it also is even getting them to you. One of the things I worked for a hospital system, we got bought out, built a new hospital, yada yada yada. But the original hospital was in the neighborhood. Patients walk there. They moved the hospital. It was only 2 miles away, but it was 2 miles away up actually, we'll call it a highway where a bus ran maybe once every 2 hours or something. And so you've erased access for a huge part of the community that you used to serve without any consideration. And so when we think about health equity interventions, it's not just in the healthcare space. We're talking about access, which means you have to talk about transportation. And we talked about education earlier. You got to talk about integrating into the healthcare system. We have to talk about, food access. Like all of these things are intertwined. And so if you're thinking about how that person shows up to you, um, where they come from, do they have somewhere to live, right? If they're diabetic, do they have a refrigerator for their insulin? And you really you really understand where your community is, and you realize not everybody has a refrigerator and stove at home. That might not be uncommon where they are. So it's really understanding the people that you're working with, understanding health happens on every level of how people live every day, and making sure that you're being aware of that. But like I said, the work has to start. Like this is not an overnight 1 hour fix, right? We have to do the work repetitively and consistently, and thoughtfully.
So that's a good point, doctor. So how if I know that I struggle and I have biases, what are some strategies for me as a provider? What are some strategies just overall to improve patient-provider communication? How do we rebuild or how do we build the trust that has to be established, right? I can't roll in with my little white coat and say, you got to trust me, girl. I look just like you, right?
Mhm.
Because there's still that angst that Dr. Bonaparte and you have discussed earlier. So what are some strategies in your opinion?
Well, like I said, attending things like this so you can have conversation. I think once you acknowledge that you're like, okay, I have this bias, looking for ways to talk with people about it on how how to understand what the truth is, what's the ethical considerations. But for the most, I mean, again, we're human. So I say lead with grace. Ask the extra question. Give people the benefit of the doubt. I think that's what, to your point earlier, is like, don't lead with an assumption. And I was just at a meeting this weekend, and our facilitator was telling the story. He said, I went to this meeting, and he's a very even-keeled, lovely, I would normally say non-biased person, but he told this story as an example of he had to check his bias. But he was at a meeting, and he said, I ended up at this table, and everybody was white and from the Midwest, and were dressed a certain way, and he was like, he was prepared to have a very tense conversation. And then he said once they started talking and they let their guard down, they realized all the things that they had in common. He said, I had to check my bias. And so I think it's just we're gonna do it. It's okay. But give give the people, because he could have just not sat at that table. He could have left. He could have said, I'm not talking. He could have done all those things. But if you're introspective enough to say, let's just see, let me hear what they have to say. Ask the next question. Okay? Don't stop at the assumption. But again, it's something that you just have to keep working through. It's not a one and done.
I love that. It's not a one and done. I used to call it a done in a day projects when I was trying to convince the dearest to do things. It was like, I'm only keeping you from the golf course one day. It's done in a day. So attacking our bias is not done in a day, right? So Dr. Bonaparte, your scholarship talks about narrative repair, right? And we've just talked about building that trust and the gap in medicine. What does your research tell us about how we rebuild the trust?
So one of the things that I always lean back into is this notion of therapeutic communication. So it's a technique that's used as a means of establishing rapport between yourself as a clinician and with the patient. Part of this comes from, or I think it bridges into this concept called narrative medicine. So it's actually using a patient's story as a way of starting to think about diagnoses and then eventually moving into a place of treatment. So one of the things that I have found in my own research is that when practitioners actually engage in more therapeutic communication, so in essence, doing some of that internal self-calibration that Dr. Fleming was just talking about of, let me make for sure that I'm not just listening for what symptoms the person has, but also thinking about what other biopsychosocial factors could be linked to what's going on with that patient. And then there's this notion of active and creative listening, right? So the active listening is you sit down, you're facing in front of the person, you're repeating back to them what they say. That's one thing. But creative listening is also thinking about empathy. So for example, if the patient comes to you and maybe there's something that's going on with like a hip, right? But they start talking about their job, then you're starting to realize like, okay, maybe the stress of the job is also linked to what's actually going on with the hip. So taking these elements of the plot, so to speak, of like what's going on with that person allows them to feel like you're actually trusting them. There's this wonderful study that's called, it's about accompaniment. And it's this idea of you as a clinician walk along the life with your patient. So not just, I just talked to you this one time in this clinical setting, but that there's follow-ups. Now, of course, there's some elements of accompaniment that would be entirely impossible. You can't always go with your patients to the grocery store, for example, and make for sure like they're picking the things that they're supposed to do. But there is this notion of, I'm actually with you. I'm accompanying you with this on this journey of not only towards a place of addressing what's going on with you, but also hopefully towards a place of health and healing. And again, I want to be really clear. I appreciate Dr. Fleming, you had said this before, that health is very expansive, right? And also our ways of thinking about health need to be expansive too. So if a person has a chronic condition, for example, their ideas of thinking about health is, I didn't have a flare up today, not necessarily, I no longer have my disease. So what I find is that when patients actually feel like they're seen and they're heard, right, that lends itself to feeling much more trust. There's a book, I should say, that I use in my classes by Dr. Groupman. It's called How Doctors Think. And in that piece, he discusses patients are able to pick up very quickly what emotions clinicians feel towards them. You'd be surprised how intuitive patients are when they're in these clinical settings. So again, thinking about that internal self-calibration that I was mentioning before, tying it to Dr. Fleming's comments, but also thinking about how do I make for sure that you know that I see you? So am I behind a computer screen, for example, the whole entire time of our clinical encounter? Or am I actually away from, or if I'm using a scribe, for example, to type things in while I'm still making face-to-face conversation with you? I also push back against this notion of cultural competency. I don't think you can become competent in a culture. So I'm not a fan of that. But what I found in my own research is that when people are culturally sensitive and culturally humble, that is when you start to see more patient satisfaction. You tend to see patients actually being a little bit more compliant and also seeing themselves of having agency and autonomy in their own, like in their own sessions that they have with clinicians. So this notion of, hey, wait a minute, like I felt seen and I felt heard. And then last but not least, I feel like I'm talking too long, so I'll just say this really quickly. There are different types of clinician-patient models that actually work very, very effectively. So there's one that's called the guidance cooperation model. And this is where patients and their clinician actually have a guided conversation, right? So you as the clinician are kind of guiding the patient along, you're giving them information, but you're also allowing the patient to quote unquote cooperate with you. So they're a part of the decision-making process. Now, you as a clinician still have a little bit more power in the decision-making process, but at least it's seen as something that's very collaborative. And then the other model that tends to work very effectively is called the mutual participation model. So this is where both the patient and the clinician are almost on the same level. So decisions aren't made without the patient saying, yes, I'm totally fine with this, I'm okay with this. Unfortunately, though, and this is the part that I do think is important to say, when we talk about building trust, we also have to be clear that health professional training doesn't necessarily always allow for those types of models to be a thing, particularly when we think about the bureaucratization of medicine. You got insurance companies that are like, how quickly did you code these things? So in essence, these are rushed encounters. So it begs this question of the reform can't only happen on an individual level, it also needs to happen on an institutional level as well, right? Like, I don't trust you because you got me in and out within 15 minutes, and then here comes the insurance company with a bill, right? So again, individual as well as institutional, to me, I find are the ways in which you start to build trust. And again, Kaiser Permanente, and there's a couple of other like HMOs that are starting to do more of this, of like actually being really mindful of this and creating measurements of, okay, are these things actually happening in the way that we need them to? So there's a lot of research out there that's showing like this can be done. This can very much so be done.
And I think something that, thank you for that. And I dropped the definitions in the chat for those who are like me. And I was like, oh, I want to remember this so I can insert it in my conversation and sound brilliant. And you said something that makes me want to go back and just highlight a comment that Dr. Fleming made, in that the onus cannot be on one individual. It can't be that physician, that solely, and so often I say we're not indicting we shouldn't indict the physician when things go wrong. I'll take a minute and give my little testimony that I have a daughter, which led to me doing this work. Prior to that, I had heard of Dr. Shalon Irving and her death, and she looked like my daughter, obviously, right? Beautiful, brilliant young woman. So I was like, okay, Southern mother, but never mind. I don't want I don't want a grandbaby. But the blessing was that I had the chance to work with so many beautiful, brilliant physicians, so we could handpick which of her aunties was her doctor. And so the wonderful story is that my daughter, I'd had complications getting pregnant. We went in going knowing that, so she was able to get pregnant very soon. Carried twins, carried them for 37 weeks, and the babies weighed nearly 7 pounds each. So we, as her physician says, she understood the assignment and then some. But then through all of that, we, the chief of peds was a friend, so he came down after the baby was born. And two things. One is, I always say it shouldn't matter who your mama knows to how you're treated. But the other piece of that story is there was somebody in the hospital that didn't care who her mama knew. And so we had a moment. And so that's why when Dr. Fleming said, it's not just about the physician, because we had a physician to this day, I will cut you if you say anything bad about her, because I love her that much. And she gave me the best gift anyone could ever do. And I give her all the praise, honor, and glory because, well, and God, but it was her skill that she saw my daughter and made sure that everything went brilliantly. But by the same token, she couldn't control everyone in that 10,000 birth hospital, right? And there was someone who didn't see us, didn't see my daughter, didn't see her husband. And her husband is an attorney that has a voice that sounds like, I'll send you to jail. And she didn't hear him either. And so there is a point where the bias takes people where they're not even rational, right? So let's talk a little bit about how do we, and many people on this call are clinicians because we are giving a CE for this class, and I'll send the instructions at the close. But how do we as clinicians or as people who are doing work in this space, how do we hold our colleagues accountable? How do we, yes, some states, California being one and others used to require that one-off training or that defaulting, defaulted to one-off training or that would require training for people to recertify. But how do we hold ourselves accountable? I'm asking both of you that question.
That answer, but also go back and respond to something Dr. Bonaparte said a minute ago.
Yes, please, of course.
So we're going from the individual to the system. One of the things that I always harp on is that I think we have to have reimbursement reform before a lot of this even matters, right? Because the system does dictate a lot of the behavior that we do, i.e., the how many visits you have to see in a day, how those visits are reimbursed. Is women's health and maternal health still the reimbursement rates are abysmal? We talk about 50% of births are on Medicaid. Medicaid does not reimburse anywhere close to commercial insured. So that interferes with access, right? Because there are certain physician offices that don't take Medicaid. And so you are already pushing people into a certain space. And then the people who do take Medicaid are often even overworked, right? Because they're trying to take care of everybody. And that's good. When I first got to Norristown, the wait time for a new prenatal visit was 14 weeks. So you almost had to know before you were even pregnant, schedule your visit. And so we got it much better. The system, they hired a bunch of us and we got it down. But that was their baseline when I walked in, and that was 2011, not that. And so all of these factors that are part of healthcare reimbursement is where we really have to have reform if we're going to make change on the individual level. But going back to your individual question, I think the other thing that we can do is lobby as a group. And so I think, and we talked about this, I think before too, there's a lot of siloing, in the country around different topics. I think we're getting a little bit better around maternal health, but I think we're going to have to coalesce and lobby together in order to get these reforms done on the state and federal level if we really want to address. I took a little departure, but
No, I think that's a very good point about, well, obviously we believe in collaboration, and that's why we were very intentional in this very long name, the importance of collaboration. And I think to your point, to have that collective voice, Dr. Fleming, and to bring that to the point of, we talked a little bit in our prior workshop about ecosystems, that it isn't just, it isn't a matter of, oh, can we change what happens in the hospital? Do we change what happens at discharge? It's what happens postpartum, because we know that 53-ish% of deaths occur when mama comes home. So who's that village? What are the protocols in place? Dr. Bonaparte, I don't want to step too far away from the topic to not allow you to give your input on, the question being again, what do we do, or how do we hold ourselves accountable from your research, from your lived experience? What do we need to do to create that culture of change? I'll stop there.
No, you're good. I really appreciate this question, largely because for me, I always think, because my students will ask me like, so how do you do that? How do you do that? And so I say, in the same way that you have an MMR, right, which is this mortality review that all doctors are, as a part of a health organization are supposed to come in and to talk about cases and what happened, what mistakes were made, what are the things that we can do for improvement. I think in the same way that it's not a review after the fact, it's actually a training that happens before that those things can actually occur. So for example, some of you all who are in the audience might be excited to know there was an article that was published in JAMA in 2022 that was actually talking about mandated implicit bias training for health professionals. And one of the things that they noted is that if you actually offer curricular elements, so in essence, people have an individual and then also a collaborative space to talk about these kinds of things, what you find is doing things is just as simplistic as like mindfulness actually serves as a way of actually helping you as a clinician to help your patient to feel less as though they're experiencing bias and more so seeing connection. Some other things that I thought were really beautiful about that study as well is that they also found is that when you have individuals who work within a health organization and they share what we call in sociology in-group identity. So in essence, I'm Black and a woman, you're Black and a woman, and having those kinds of conversations between people who share the same group identities, and then also then building out from those conversations and talking with people who don't share those same types of identities. Those kinds of conversations actually make a huge difference. And then also there's another piece that came out by Ching et al. This was, I believe, in 2023, where they actually did an actual coaching program within a medical center across an entire medical center. And they had some amazing results. Some of those results included things like noting how and why these coachings lent itself to people actually doing something better and being more accountable for them, not only themselves, but also for other people. And so this was a longitudinal study that was done over, I believe, 4 years. So literally within year one, they started to see a larger level of self-awareness. And not only did you see this larger level of self-awareness, then it built into year two, where you actually started to see a shift in regards to surveys being done with patients. And the patients were even saying, I'm noticing now, right, that I'm experiencing less bias than I had previously. So these types of things can work, and they can work really effectively. So when you have that kind of commitment on behalf of a health management organization or a part of a medical center, you can actually see these things in real true time actually start to shift and to change. But I think at the end of the day, we also have to be honest about what oftentimes happens, particularly amongst doctors, right? Doctors tend to protect themselves sometimes. So they may know someone's doing something and they may not say anything because they're like, well, I'll just try to have like an individual one-on-one conversation. But if this is a person who's consistently engaging in a cycle of hurt, this is where those types of accountability measures are just so important. So important.
That is the policing your peers is an important part. I know, we see it not only in so many professions because we talk, physicians, police, law enforcement, that I may know that my buddy is not following protocols. I tried to find the Jank study. I'm normally really good at finding as people talk. And it kept taking me just to the JAMA page, but I'm going to drop the summary in for you guys. I want to open the floor. I know we've got a lot of people in here and you guys have been quiet. I know you are chomping at the bits. If you've got questions or comments for our panelists, please drop them in either the Q&A or in the chat. Otherwise, I will keep asking questions because I've got so much I want to ask. And I'll talk amongst ourselves while we are waiting for you guys to type the questions in. Or if you raise your hands, we can't put you on camera because that function doesn't work, but we can unmute you to allow you to share your thoughts, your comments. I know there are a couple of people on here that I know that have a lot of thought. Thank you, Susan. Susan Lowe, who is a wonderful mental health professional in Southern California and serves on the board of oh gosh, it's a community-based health organization that provides community doulas, et cetera. Said that is, quote, very excellent presentation. So it's high praise. And Susan, I'm sorry, drop the link in for everyone. My brain I keep wanting to say Dr. Saida Uplifts, but I know that's not your organization. That's your brilliant daughter. But I'm having a senior moment. So while we are waiting for the group to come in, I have a couple of other questions. And maybe I'll pose the question for the group, or no, I'll come back to them. What do, and you guys alluded to this a little bit in terms of how, I love your comment, Dr. Fleming, on how the system dictates behavior. So then that leads to the question of what do systems need to do or need to unlearn in order to make room for equity? We talked a little bit about how there are parameters around the amount of time one spends with the patient, et cetera. But let's spend a little time on that, could we?
I feel like Dr. Bonaparte earlier said that's a whole nother several hours.
Another workshop.
I think There's so many levels to systemic change. One, I think again, naming a name, naming a thing. Um, but we have to realize, kind of going back to that historical perspective, the system is designed to produce the outcomes that it gets, right? And so our whole system has been broken since it started, right? We were built in a segregated system. We were built with disparate resources to different communities. We can go back and talk about redlining. We can talk about where academic institutions were built, and thinking about safety net hospitals often being attached to those academic institutions. And so there's a lot of layers that we would have to think about when we would go through systemic change. But we really, like I said, I think it comes around reform. I mean, we have to think, all the words, right? We have to think about there's still a and we talked about physicians and police and peers, but um, there is still a hierarchy in medicine. There's still a large element of patriarchy in medicine, right? And so, we have to work through all those things simultaneously in order to improve the system. It's not a quick fix. It's not an overnight fix. I think it requires leadership that believes that everybody should have equity care, which that's can't say that that's true about all of our leaders. If we start with leadership that believes that everyone should have care and then puts the resources be behind making that would be, I would say, step of many.
Um, thank you, Dr. Mary. I think there's so much, well, I'm capturing notes. And I love the point that you said about, leadership must name it as a priority, invest accordingly. Because I think so often we give it lip service, for lack of a better word. Is it, or is it something marketed like baby friendly? And is it truly baby friendly? And and I would submit that in my prior life, I've had some circumstances where leaning into the whole baby friendly conversation, but in talking to Black moms in those hospitals, you're spending, countless dollars to be labeled baby friendly or to get that certification. But then your Black mama gets 10 minutes of counseling from your IBCLC because she's rolling in and wants to roll back out and is not comfortable. So I won't go on that rampage. That's a whole other conversation for Black Breastfeeding Week. But I do see that before we let you share your thoughts, Dr. Bonaparte, there is a retired physician that's in the chat, Dr. Leslie Farrington. And Dr. Farrington, you had some commentary?
Yes, I put it in the chat, but
Oh,
I was notorious when I was practicing that we would have mandatory trainings of various kinds, and then we could get through them without really indulging too much real change in ourselves, real learning. So it was encouraging to hear Dr. Bonaparte describe the study where people actually interacted and that made a difference. But what do you see? How do you see us being able to get past that, lip service, as Marie called it? That's all. I just wanted to address that because really doctors don't have that kind of time or energy
Right.
to devote to something they don't see that they personally have anything to do with.
Mhm, mhm. I love, first of all, I think we follow each other on LinkedIn. So I was really excited when I saw your name pop up in the chat. And also just really grateful to have a conversation with you as well, Dr. Farrington. Thank you so much for the work that you do for the coalition as well. I know for myself, I always find, even before we get to the trainings, is expose people in the very, very beginning, right? So for me, because I tend to focus on maternal health care, I always think about in medical school, expose people to things. I'm going to plug my book for a quick second. I have a wonderful book. It's in its second edition called Birthing Justice, Black Women, Pregnancy, and Childbirth. And in it, we have sincere like essays that are written by people who have talked about their own birthing experience. We have conversations between a mother and a daughter, for example, talking about what does it mean to support people. And then at the latter end of the book, we actually offer like, these are the things that you can do. These are the types of interventions that can be available. I also think about reading other types of books like Dana Ann Davis's book, Reproductive Injustice. Like, to me, I find medical school is not just learning the mechanics of the body, right? And illness and disease. It's also, what are these types of social things that are potentially influencing how people are healthy or how people are sick? And in addition to that, how what people are bringing into the room is not just a body, but an actual lived experience. And so to me, I feel like that should be part of the training. I'm always very heartened when former students of mine have gone into medical school and they say, you will not believe this. The book that you had us read in undergrad, we're actually reading it now in medical school. And I'm like leading a study group on it. But like that to me is how you start to shift things so that when the training comes along and that socialization comes along, there's a counter. Well, wait a minute. What I've learned actually is that there are these other kinds of pieces that are at play. The first time I'd ever shown someone that the image of that painting that I just showed you all earlier, they said, I didn't even know any of this history. And so to me, right, you have to know this history if you're going to practice medicine on folks of color, on poor people, on the experiences of queer folks, trans folks, you name it. Like, you actually need to know the social histories of people to really be able to do what you're supposed to do according to the Hippocratic Oath, which is do no harm. So again, I really want to say, Dr. Farrington, I really appreciate not only your question, but also this notion of we have to go beyond lip service and then just required, I did something through a computer program training, but actually the training starts even before you actually become a practitioner. And I think that, and then the continuity of that training then becomes a thing. So I'll end there on that comment.
Oh, thank you. I think there's a comment in the comments where the person asks, says she's not Black. She isn't a person of color. And so her question was, how do I want to say it exactly right. Would I still be able to join certain leaderships like this? I do understand all the topics brought up from a minority perspective. Reactions, comments, how would you respond?
Her answer is yes, please. So one of the things that I do is I teach a leadership development course on leadership and equity in healthcare. And we define healthcare broadly. So if you can tell me that you're in healthcare and it makes sense, sure, right? So we want to be really broad-based in our approach, but also across it's across disciplines, across the country. We have international students. We've had people as far away as Poland, and we had several people from Canada. Everybody, this happens everywhere. This is not unique to the United States. It's not unique to Louisville or New York or Houston or LA, right? This is a broad issue, and there's application. We talk a lot about racial and ethnic disparities. When we talk about rural health, it's all the same things, right? That when people don't have access to care, their outcomes are worse. So we just got to fix it. But it has to be an all hands on deck. We can't just depend on the people who are marginalized to fix it, right? First of all, we didn't break it. And second of all, not enough of us to fix it. So yes, please come, whatever you're interested in this conversation in this lane. Let us know how to help you get to where you want to be. But absolutely.
Thank you, Dr. Fleming. I echo her. And there are a lot of people saying they want to meet you both. So we'll capture the chat and we'll share it, and then we'll also share. I've shared their websites in the chat, but we'll include it in our email. I can't believe this hour has gone this fast. But I have a challenge for our audience. I had a couple of questions for you, but we don't have time for that. We will definitely have to maybe have a part 2. But I ask you to drop one word in the chat that captures what you're taking away from this conversation today. What did you learn? What surprised you? What challenged you? What is something that you're taking away? I'd love to know. While you're doing that, I will pull up the QR code For those of you who are still, that are wanting to get your hour of CE, let me pull up that QR code for you and scan it. If you have difficulty scanning it, we'll also send it in our email to you so that you can access it. Trying to get it big enough for you to see. And we've got a couple of questions that, as you know, you just answer those questions and then we'll get a certificate to you. While I'm doing that, I want to thank our amazing, amazing panelists again for your time today. It was so wonderful to have this conversation with you. I think it's, there are so many words that I could take away. So let's see what people are putting in the chat. Let's see, one word: collaboration, persistence, do better, a lot of hearts. Yes, please, to a part 2. Power, resilience, and insight. Thank you so much. And being beneficent. But y'all gonna make me say it, and I'm Southern. Y'all, by the time I get rid of the Southern accent, there are certain words that are just not going to come. But thank you so much, Angie, for that. Being beneficent. We can't say it. It's not coming.
Beneficent. I got you. Beneficent.
Thank you, my girl. It's not working. Ethics are counters to bias. I want that on
That
a
was good.
I want that one on a shirt. Speaking of shirts, if you guys have not noticed, Birthing the Magic has a wonderful message. So I encourage you all, go to our website, birthingmagic.org, grab your shirt so you can, we may have to steal this one from you, Dr. Bonaparte. We'll put your name on it. But grab your shirt, stay with us this afternoon. We've got 2 more workshops. And we are going to talk about a plethora of things. One is, and this came up in our previous workshop with OBs and those who are doing work in the space, that they talked about the importance of preconception. And we know that yes, 50% of births are unplanned, but we're going to have some conversations about things that you can do even if you aren't necessarily actively planning to get pregnant, but preparing you. So it's called Ready, Set, Go. It's a pre-pregnancy pep talk. That's going to be at 6:30 Eastern. So in about 30 minutes. And then after that one, we have a conversation about some of the things that might go wrong in your postpartum period, or things to do to avoid things going wrong, both of which are worth your time. If you haven't registered, we don't close the registration until a minute before the workshop starts. Again, I want to thank both Dr. Bonaparte and Dr. Fleming for your time and your brilliance today. I am just so filled, and I think so encouraged as a grandma and an auntie, and that have these, nieces and nephews and folks that are still having children, that there are people in the world that are doing the work that you all are doing. Maybe I won't have to fast and pray quite as hard next time, but thank you so much for your time. Thank you all for joining us. And for those who are sticking around, we'll see you in about 30 minutes. Have a good night.
Bye.